Breathing is simultaneously the most automatic and the most accessible voluntary physiological process available to human beings. You do it without thinking approximately 20,000 times per day. You can also, at any moment, consciously alter its rate, depth, and pattern, and in doing so, produce measurable changes in cardiovascular, neurological, and immune function. That combination of automaticity and voluntary control makes breathing a uniquely powerful lever for influencing the autonomic nervous system, and the science investigating that lever is finally reaching a level of rigor that clinical medicine can no longer comfortably ignore. The autonomic nervous system governs the balance between sympathetic activation, the fight or flight response, and parasympathetic recovery, sometimes described as rest and digest. Chronic imbalance favoring sympathetic dominance is associated with hypertension, anxiety, inflammatory dysregulation, and impaired cardiovascular resilience. Heart rate variability, the beat-to-beat variation in the interval between heartbeats, is the primary clinical measure of this balance. And it is a meaningful predictor of cardiovascular and all-cause mortality risk in ways that are now well established in the literature. Research from Stanford's neuroscience groups and others has demonstrated that specific breathing patterns produce measurable autonomic effects with a speed and magnitude that comparable mindfulness practices do not match in head-to-head studies. The cyclic sigh, a double inhalation followed by a slow extended exhalation, activates the parasympathetic system more effectively than almost any other available intervention in the acute stress context. Paced breathing at approximately 5.5 to 6 breaths per minute, which happens to align with various traditional contemplative practices across cultures, optimizes heart rate variability in ways that training studies are beginning to show have durable cardiovascular effects for hypertension, anxiety disorder, PTSD, and post-cardiac event recovery. The evidence base for structured breathing protocols is now sufficiently robust that clinical integration is not a matter of scientific justification. It is a matter of clinical culture and professional willingness. The actual barrier is not evidence. It is the association between breath work and yoga studios, wellness retreats, and the broader cultural landscape of alternative health that makes conservative clinicians instinctively skeptical regardless of the mechanistic data. That cultural hesitation, while understandable, is a form of bias that is costing patients an accessible, low-cost, side-effect-free intervention with documented efficacy. Unlike many wellness-adjacent recommendations, controlled breathing requires no equipment, no subscription, no pharmaceutical, and no significant time investment. The cost-to-benefit ratio is extraordinary by any clinical standard. The honest caveat is that not all breath work practices being marketed in the wellness space have equivalent evidence behind them. Hyperventilation-based practices like certain Wim Hof protocols carry real physiological risks when practiced incorrectly or without medical supervision, particularly in individuals with cardiovascular conditions. Distinguishing evidence-based protocols from commercially packaged experiences requires clinical guidance that most patients currently have to seek out independently. The legitimization of this field by mainstream medicine would help draw those distinctions more clearly, and that legitimization is overdue.